Chapter 26, Acute Myeloid Leukemias. So all acute leukemias are stem cell disorders, and they're characterized by a malignant neoplastic proliferation and accumulation of immature hematopoietic cells in the bone marrow that also have a problem functioning. These cells show an increased proliferation and or decreased programmed cell death. Therefore, the net effect would be the expansion of the leukemic clone and over time, a decrease in normal cells. This clonal expansion is usually a single transformed cell. Therefore, all of the acute leukemias begin before any clinical symptoms appear. Lethal levels of tumor burden are known to be at cells of 10 to the 13th or higher, and as this expands, the normal function of the bone marrow cells decrease. So what's usually seen is that clinical triad. So we've also seen it before in many other conditions. We have anemia, infection, and bleeding occurring from the cytopenias. And death in patients often occur from either infection or hemorrhage in weeks to months unless there's some kind of therapy intervention that occurs. The two major categories of acute leukemias are classified according to the origin of their cell. So AML is acute myeloid leukemia that affects primarily the common myeloid progenitor, whereas ALL, acute lymphocytic leukemia, affects the common lymphoid progenitor. Now, within those categories, there's also subtypes, and they're identified by their cell markers and by any kind of genetic abnormalities identified with those categories. So we're going to learn about the WHO classifications of the categories of AML today. So to classify this disease, it's characterized by two fundamental cellular features. First, it has an ability to proliferate continuously and have an arrested development and maturation. So excessive proliferation can be the result of a mutation that affects growth factors, their receptors, or any kind of signaling pathway that leads to factors that increase the cell survival and the proliferation rate. So the majority of genetic mutations here that have been identified with AML do involve those transcription factors and those signaling pathways, so things are turned on constantly. More than half of these cases display some kind of cytogenetic abnormality. Now, most are balanced or reciprocal translocations, where you have many of the breakpoints located at a loci for genes that encode those transcription factors as well. The most common consequence of these is the generation of a fusion gene that codes for a novel fusion protein. And these proteins are formed usually after or alter the normal function of these rearranged genes and modify normal programming of cell proliferation, differentiation, and survival. Now let's discuss what can be seen in the peripheral blood of an AML patient. Now this can be quite variable depending on the stage the patient is found in. So although it is traditionally to describe leukemias as having an elevated white cell count, which is 50% of the cases have a decreased count or counts within the normal reference range at the time of diagnosis. So you could see a white blood cell count ranging anywhere from 1 to over 100. Regardless of the concentration, the presence of the blasts in the blood smear suggests a diagnosis of acute leukemia. The WHO classification definitely needs a minimum of 20 or more blasts in the peripheral blood or bone marrow. Cases have to be classified based on the combination of immunologic, cytogenetic, and molecular genetic factors, in addition to those cytochemical stain tests. Typically, the myeloblast you're going to see is about 20 microns in diameter with a very prominent nucleoli. And we're going to get into some images in a minute. Red cells are typically decreased with a hemoglobin value of less than 10 is very common. You might start to see a slightly macrocytic ability because they have an inability to complete or compete with neoplastic cells or folate or vitamin B12, and they release early reticulocytes. So in addition, you can also see red cell inclusions such as Howell-Jolly bodies, Pappenheimers, or basophilic stippling, reflecting the maturation defects in the red cells. You can also see nucleated red blood cells as well, in proportion to the anemia or marrow damage that is present. Platelets are typically decreased, and you might see hypogranular platelets or the occasional large platelet. And as a disease progresses, you're going to have more immature platelet forms seen as well. Other abnormalities include monocytosis and neutropenia, and the neutrophils may exhibit some signs of dysplasia, such as hyposegmentation or hypogranulation. Here's an example of a peripheral picture where you see a number of blasts in the field of view and varying stages of immaturity in the granulocytes and dysplasia in the red cells and hypochromasia. Bone marrow testing should include both the aspirate and the biopsy for specimen types. The quality is very critical for analyses because it's typically presenting as a hypercellular image with a decreased fat content. Now again, this is relative to the age of the patient, and there's a predominance of blasts, sometimes an increase in fibrosis. So with the WHO classification, you want to see at least 20% blasts of non-erythroid nucleated cells to distinguish acute leukemias from myelodysplastic syndromes. Now, testing on the bone marrow is going to include flow cytometry, any kind of cytogenetics, molecular diagnostics, going to perform a differential on the bone marrow as well, and any special chemical, cytochemical stains. On the biopsy itself, you're going to do a special tissue stain or immunohistochemical stain to identify any of the abnormal cells. So here is a clinical finding of a bone marrow core biopsy put on a slide and stained, and you can see the hypercellular image here and very little fat, and the arrows are pointing to a very large nucleus compared to the other cells in this image. Here is a picture of a normal cellular bone marrow where we have an adequate amount of fat to cell ratio. Now here is an image of a myeloblast that has been seen in an AML patient, and a lot of the times in the peripheral smear you could have a blast count that's close to 100% of your differential. And our rods are present in about half of these cases. So this image seen in the arrow is an hour rod. So this is something you're going to be identifying that will classify a myeloblast. So the presence of an hour rod, okay, so that is a fused or coalesced primary granule, and it looks like a rod-shaped inclusion in the blast, and this will exclude this from being a lymphoblast because it's only seen in the myeloblast. Okay, all myeloblasts have high nucleus to cytoplasm ratios and 1 to 5 visible nucleoli. Okay, you may start to see this little parahalo nuclear area where the Golgi is also formed. In 2008, the World Health Organization made classification categories for the umbrellas of acute myeloid leukemia. They are considered and based on first having over 20% blasts, and then characteristics defined by either morphology, cytogenetics, molecular genetic abnormalities, cytochemistry, flow cytometry, and any clinical findings. So let's get to the 6 categories here. So the first group is AML with recurrent genetic abnormalities. So this is used when recurrent chromosome abnormalities, usually an unbalanced or some kind of reciprocal translocation, is found. In most cases, these chromosome rearrangements create a certain gene fusion and provides a novel fusion protein. So the first group here is AML with a translocation in chromosomes 8 and 21. And this is found in about 5 to 10% of all AML cases. It was previously called AML with maturation because you can see some mature cells along the way. It occurs primarily in children and adults under the age of 60. Myeloblasts are usually large with abundant cytoplasm, and they might contain our rods. The next AML with an inversion 16 chromosome. This category is identified in only about 7% of patients with AML and present with a monocytic and granulocytic maturation and the presence of abnormal eosinophils in the bone marrow. AML with a T911 translocation are usually associated with monocytic features, mostly monoblasts and promonocytes. They can occur at any age but are more common in children. So about 25% of those cases are in children, and they account for only 2 to 5% of all AML cases. They can also be related from therapy-induced treatments. The next category, AML with a T1517 translocation, is very important because this is a specific promyelocytic type of variant, okay, where predominantly promyelocytes are there. They can be hypergranular and hypogranular in their presentation. They can occur at any age, but most patients are adults and in middle life and constitute about 5 to 8% of the AMLs. What's really presenting here clinically is a lot of the patients often go into DIC due to the granules within the promyelocytes. There has been a specific treatment for these patients using an ATRA treatment, which is an all-trans-retinoic acid. It's proven to be effective in blocking the translocation fusion. AML with inversion 3 chromosome can be present from a prior MDS. It can be associated with normal or elevated platelet count with atypical or increased megakaryocytes that are mono or bilobulated nuclei, and it accounts for about 1 to 2% of all AML. AML with a translocation 122 generally shows maturation in the megakaryocyte lineage, but it's very uncommon, representing less than 1% of all cases, and it can be restricted to infants and young children, with most cases occurring in the first 6 months of life. The presentation is definitely an enlarged liver, and they can also have anemia and thrombocytopenia. There has also been AML with gene mutations that do not result in an abnormal karyotype, and this includes certain genes related to tyrosine kinase 3, such as FLT3 or nucleophosmin NPM1, and less common mutations of CEBPA. So the next classification, we're going to talk about AML with myelodysplasia related changes. And this category is an acute leukemia with morphological features of a myelodysplastic neoplasm, a prior history of MDS, or a myelodysplastic myeloproliferative neoplasm with some kind of MDS-related cytogenetic abnormality. And to classify this as AML with these myelodysplastic changes, by morphology, the dysplasia has to be present in at least 50% of cells in at least 2 of the cell lines. The third category here is therapy-related myeloid neoplasms, and this includes therapy-related acute or AML, myelodysplastic treatment, and MPN-MDS therapy-related causes of transformations. AML occurs as a late complication of the cytotoxic chemotherapy drugs or from radiation therapy from a previous malignancy. Category 4, myeloid sarcoma, refers to a disease in which a tumor mass of myeloblasts occur in the extramedullary sites or in the bone. It can occur with acute or chronic myeloid types of leukemias or other kinds of MDS, MPN types of categories. Now, category 5, myeloid proliferation related to Down syndrome. So these children with Downs have a 10 to 100-fold likelihood to transition to an acute myeloid leukemia. And this can happen within the first 5 years of life, and only about 1 to 2% of children with Down syndrome will develop AML during this time. The 6th category is a plasmic plasmacytoid dendritic cell neoplasm, which is very rare, but it's an aggressive type of neoplasm derived from the precursor of the plasmacytoid dendritic cells, and has a high frequency of cutaneous and bone marrow involvement in leukemic dissemination. They can present with skin lesions that can be nodules or bruise-like areas. And last but not least, acute myeloid leukemias that are not otherwise specified, meaning they don't fulfill the criteria of any other described group, and they can primarily be differentiated on their morphology and cytochemical features, again defining characteristics of greater than or equal to 20% blasts here. So first, AML with minimal differentiation is very rare, but it's characterized by the lack of myeloid differentiation by morphology. The subtype is has a very poor prognosis, meaning most of the cells are immature blasts and have no morphological differentiating features. Now, AML without maturation is characterized by a high percent of bone marrow blast without any evidence of maturation to more of the mature neutrophils. It can occur at any age and accounts for 5 to 10% of cases, but mostly in adults. They can present with bone marrow failure and a leukocytosis. AML with maturation, it still has 20% or more blast, but you can see evidence of maturation to more mature neutrophils, meaning greater than 10% of the cells at differentiated stages of maturation, and you can see different stages like promyelocytes, metamyelocytes, and such, and can occur in ages of less than 25 years old or greater than 60 years old. Acute myelomonocytic leukemia is characterized by the proliferation of both myelocytic and monocytic precursors. So you're seeing hypercellularity in the bone marrow with greater than 20% blasts, neutrophils, and their precursors, as well as monocytes, compose each greater than 20% of marrow cells. It accounts for about 5 to 10% of all AML cases. The other classifications are named due to their predominance of their population of cells. Now, because blasts are immature, they're very hard to identify morphologically. So in that case, we have to do the identification using cytochemical stains, molecular testing, and immunophenotyping. So let's start off with the cytochemistry identification of AML. You're going to have your own separate flow cytometry lecture, so we'll focus on these cytochemical stains. So the first most common stain is a myeloperoxidase. So this is a stain that you're going to do, and if it's a granulocyte, it's going to present with these blackish granules. So they stain positive, and this can differentiate a myeloblast from a lymphoblast. So they're positive in myeloblasts, negative in lymphoblasts, monoblasts, and erythroblasts. The next stain is Sudan black. Again, those bright black granules will identify the difference between an acute myeloid or a myeloblast between a lymphoblast. So it stains the lipids of those cytoplasmic granules, which has the same staining pattern as myeloperoxidase. So again, we're just distinguishing the blasts of lymphoid to myeloid lineage. Now, when we get into the esterases, so specific and non-specific esterases, these are helping to differentiate precursor granulocyte cells from monocytic cells. So here we have a chloroacetate esterase, which is specific esterase, and it's specific for myeloblasts. So you'll see the reddish granules coming up positive in myeloblasts, and then will be negative in monoblasts or lymphoblasts. So that is another distinguishing factor. The next is a non-specific esterase called alpha-naphthyl esterases. Again, these bright red granules identify monoblasts. So they will be definitely negative in myeloblasts and lymphoblasts. So they're differentiating the specific and non-specific from monoblasts to myeloblasts, and completely ruling out lymphoblasts. The mode of identification is immunophenotyping or flow cytometry. So it has become very necessary to identify the surface markers of these cells, definitely when they are immature. So the use usually is specific because it tests a sequence of monoclonal antibodies, and they can be set up as a panel to identify and distinguish the different types of immature cells and at what stages. And you will get a separate flow cytometry lecture soon. Now, 2/3 of patients with AML have some kind of genetic or cytogenetic abnormality or translocation. So a lot of the commonly observed ones are trisomy 8, monosomy 7, monosomy 21, trisomy 22, or a loss of an X or a Y chromosome. These translocations result in fusion genes that are either beneficial for proliferation and survival or disrupt the maturation process. And you saw that in the classification in category 1. Here's a peripheral blood picture of a patient with AML. Notice the very prominent granules and the hour rod in the blast on the left, the fused primary granule in the top of the cell. Now it's very clear here because the cytoplasm is very fine and lacy there. Here is a bone marrow aspirate, and this is the differential, and you can see definite blasts, the top cell being a blast, and those other promyelocytes having those very dark, prominent primary granules. Here's a peripheral blood film from a patient with AML with maturation. So you have a couple blasts, and then you have a couple mature neutrophils at the top of the smear. Here's a peripheral blood film with a patient that has an acute myeloid and monocytic type of a leukemia, where you see monoblasts and pro-monocytes that are present. And again, very hard to differentiate here, so you'll need to do some cytochemical staining and flow cytometry as well to identify. A smear from a patient that has acute monoblastic leukemia, where you have a predominance of monoblasts and pro-monocytes. And lastly, you have erythroblasts with megaloblastoid features in a patient with acute erythroid type of leukemia. You can see that the nucleus here is more condensed in the red cells as it is for the myeloblasts. Now, traditional therapy for AML is chemotherapy because we want to reduce the tumor load as quickly as possible. But there are many new treatments coming out, especially that ATRA, which is a targeted therapy specific for APL. Please know that. There are some kind of epigenetic targeted therapies as well as bone marrow transplants, either allogenic or autologous, and infusions of donor lymphocytes with total body irradiation can also help to decrease the leukocyte infiltration and destroy those cells.